What's going on, guys? How's it going? Today, I was going to review the frontostriatal pathway. It's a very important pathway to sort of understand, particularly if you're trying to sort of get a good idea of what's going on with the patient. For the most part, you look at the cluster of symptoms the patient's having, and you try to trace it back to the lobe. And then you see what are the networks in that part of the brain. And then that way you can sort of drill down on the circuitry to get a good idea of what's causing the disturbance. You know, if you know what the receptors are like on this pathway, then you have a good idea of what tools you can use to intervene. So here I'm on Chat GTP. And just let me just ask it here. Okay, let's see here. Explain the frontostriatal. Explain the frontostriatal pathway. Function and focus on the functions and receptor profiles, right? Okay, we're about to get into this. Okay. Okay, let's see here. Okay, let me go ahead and start up here. Okay, excellent question. The frontostriatal pathway, also called the frontostriatal circuit or the frontostriatal loop, is one of the most important brain systems linking the frontal cortex to the basal ganglia and the thalamus, and playing a central role in motivation, reward, cognition, emotion, and executive function. Understand this. This is very important to sort of understand this. So this connects the frontal lobe to the basal ganglia and the thalamus, right? The frontostriatal pathway, all right? Playing a critical role in motivation, rewards, cognition, emotion, and executive functioning. Yeah, because that frontal lobe, you want to connect that frontal lobe and get the input for that executive functioning. You know, let's break it down. For the anatomy, the frontostriatal pathway connects the frontal cortex to the striatum, to the globus pallidus and the substantia nigra, to the thalamus, and then back to the frontal cortex. This creates a closed loop circuit, meaning the output feeds back the same cortical regions that initiate the signal. The frontostriatal loop. Frontal lobe, especially the prefrontal areas, such as the dorsolateral, orbital, frontal, anterior cingulate cortices. Next to the striatum, the caudate nucleus, and the putamen. Then the globus pallidus, the pallidum, and the midbrain substantia nigra, and the ventral anterior mediocre nuclei. Yep. And back to the thalamus, the frontostriatal pathway. Okay, the functional circuits within the pathway. These are several parallel frontostriatal loops, each serving a different function. So, for example, the motor loop, okay, the frontal organ, okay, you have the oculomotor loop, you have the dorsolateral prefrontal loop, the orbital frontal loop, and anterior cingulate loop. Okay, so let me just try to organize this. Okay, the motor loop. Okay, it originates in the motor area through the putamen, and movement, it initiates and control motor movement. That's the motor loop, all right? Okay, there are several parallel frontostriatal loops, each serving a different function. The ocular motor loop, frontal eyelids, the caudates, and this is for eye motor movement. Yep. Look, dorsolateral prefrontal loop. Dorsolateral prefrontal loop. Wow, man, we have to look at that dorsolateral prefrontal loop next, because the dorsolateral prefrontal cortex is thought to be the seat of the ego, and that's what we're trying to sort of dismantle. So the dorsolateral prefrontal loop, the dorsolateral caudate, again, look, executive functioning. Look, working, memory, and planning. Very important. Orbital frontal loop. The orbital frontal loop, the ventral medial cortex for impulse control, reward, evaluation, emotional regulation. Damage to that orbital frontal loop, impulse control, reward, drug seeking, emotional regulation, impulsive behavior. Anterior cingulate loop, the anterior cingulate cortex, a ventral striatum, this motivation, drive, conflict, monitoring. And so there are several frontal parietal loops. Great. And so they come from the cortex to the side. Okay, great. Okay, core functions. The frontal striatal circuits integrate cognitive, emotional, and motor control. Yeah. Selecting and initiating actions such as motor and cognitive, suppressing inappropriate behaviors, mediating reward-based learning, linking motivation, that is goal-directed behavior, and regulating executive control such as planning and decision-making. Next, damage or dysregulation can lead to executive dysfunction signals. Yep. Mood and motivational changes, movement disorder such as Parkinson's disease. Yeah. See, remember, this is one of the pathways that's sort of injured in schizophrenia too, and I think the degradation, damage to this pathways may be the mechanism that creates the diminished sensorium or the cognitive differences, the cognitive damages or cognitive differences in patients with schizophrenia. So let me just review this again. You have this frontal striatal circuits. They integrate cognitive, emotional, and motor control, right? Remember, in schizophrenia, the diminished cognitive processing things, the diminished emotional range or apathy and things like that. And then also with schizophrenia, the motor movement, things like that. So, damage to this frontal striatal circuit, as you can see how you can sort of see the areas that the patient will have the most dysfunction in, meaning cognitive areas, emotional areas, or movement disorders area. Next, selecting and initiating actions. Yep. Suppressing inappropriate behaviors, mediating reward-based learning, linking motivation such as goal-directed behavior, regulate executive control such as planning, decision-making. Damage or dysregulation can lead to dysexecutive syndrome. See, there's another name that I use for here. It's called executive dysfunction. So this is there are persons behaving in a way that shows no planning or organization. It's just random behaviors and reactions, blind and unconscious reaction from their ego in response to their ego. So this executive syndrome, such as schizophrenia, ADHD, and frontotemporal lobe dementia, right? Mood and motivational changes such as depression, apathy, or OCD. Yeah, OCD, movement disorder such as Parkinson's disease. So remember, the cognitive, the emotional, and things like that. See, the cognitive and emotional, that would be frontotemporal lobe dementia. Motor would be sort of like Parkinson's disease and things like that. Okay, so let's look here next. Receptors, the neurotransmitters and receptor profile. The frontal striatal system depends heavily on dopamine, but also involves glutamate, GABA, and serotonin. Dopamine, origin substantia nigra, okay, and VTA, ventral tegmental area, projects to the striatum. Okay, the receptors, D1-like receptors, mainly on the direct pathway, D2 receptors on the indirect pathway. Okay, so we have dopamine receptors, D1 receptors, D2 receptors. Okay, we also have glutamate receptors on the pathway. The cortical inputs to the striatum is glutaminergic, excitatory. It acts on NMDA, which is a type of glutamate receptors, and AMPA, which is another type of glutamate receptors. They mediate top-down control and goal-directed activation. So let me go through this here. So this frontal striatal circuits is primarily heavily dopaminergic, so it involves D1 and D2 receptors. So if the patient's having difficulties in this area, then the antipsychotic medications, particularly, and the antipsychotic medications can be used. Now, the typical antipsychotics like Haldol and Prolixin, they primarily bind D2 receptor, right? But the atypical, they also bind D1, D2 receptors and the other receptors too. So both typical atypical antipsychotics can be used in this situation. Okay, here, and then of course glutamate is the main excitatory neurotransmitter, and so of course the cortical inputs from the striatum is glutaminergic, and so of course when it activates those pathways, it's going to activate glutamate because you need to get things turned up, right? Okay, next, the other major neurotransmitter that turns everything off is GABA. Glutamate and GABA are present in practically all of the tissue. Glutamate, and so when you activate glutamate, you get a systemic response of activation. When you activate GABA, you get a systemic response of inhibition. So glutamate turns the whole organism on and up, and GABA turns the whole organism off and down, right? And so the cortical inputs to the striatum are glutaminergic, excitatory. NMDA is one of these type of glutaminergic receptor. AMPA is another type of glutaminergic receptor, right? GABA, this is a main neurotransmitter within the striatum. Okay, this is the main, I guess it has to be the main one to shut things down, right? Medium spiny neurons are GABAergic neurons that inhibit output nucleus, right? They provide inhibitory control within the loop. So the main neurotransmitter in the striatum is an inhibitory neurotransmitter, glutamate, GABA. And alcohol is a target for GABA, right? And so this is one of the reasons how alcohol can influence the person's perception of things. Because look, remember, we're talking about this frontostriatal circuit, and the main neurotransmitter is GABA, and GABA is the target of alcohol, right? And so remember, alcohol impairs the frontostriatal circuits, and you get the executive dysfunction system. Like, why did you do that? I don't understand that. You get the mood disturbances and the motivational changes and things, and then you get the movement issues like severe agitation, combative aggressive behavior. This could, you can see how alcohol is not a good selection of substances to use if you have any type of challenges to the stability of your frontostriatal circuit, right? Because otherwise, when it hits those switches and then you start having all these difficulties because it's a malfunctioning frontostriatal circuit, then the consequences can be very severe, right? So the main neurotransmitter within the striatum is GABA, and GABA provides inhibitory tone, right? Okay, next, also serotonin, acetylcholines, and others. Serotonin modulates motivation and impulsivity via the 5-HT1B, and acetylcholine from the striatal interneurons regulate dopamine release and plasticity. All right, sounds good. And so remember, also for this glutamate GABA issue, if the patient coming in with these issues, Depakote is an option for this, because Depakote will increase the level of the threshold for a action potential, and it will have the overall effect of slowing the traffic down across the network. And Depakote will also, in addition to lithium, will also cause long-term down regulation of those glutamate receptors. And so patients with the psychosis, schizophrenia, psychosis, mood, or substance abuse disorders that may have damaged or injured their frontostriatal pathway, we can use Depakote to sort of stabilize that pathway by hopefully resulting in the long-term down regulation of glutamate that's very excitatory, and upregulation of GABA, which is very inhibitory. So hopefully the medication over time help balances the receptor profile so the patient exists in a more balanced, peaceful state, not in a hyperglutaminergic state. Got me? Great. Look, clinical relevance here. Okay, for Parkinson's disease, the loss of dopaminergic neurons in the striatum, decreased D1 or 2. Okay, great. Schizophrenia, dysregulated prefrontal dopamine. Schizophrenia, dopamine, prefrontal dopamine, glutamate dysregulation. Look, hypofrontality and working memory deficits. You know, that hypo for that. See, in schizophrenia, see dysregulated prefrontal dopamine glutamate, meaning the frontal lobe can have hypoactive dopamine. It can be hypodopaminergic, and therefore one of the antipsychotics, Abilify, works very uniquely because Abilify is a dopamine agonist, not a dopamine antagonist. It's just that it activates dopamine just a little bit, not a lot. So overall, it can significantly decrease dopamine hyperactivity simply because it activates a little dopamine at a time, not just a lot of dopamine. So medications like Abilify as an antipsychotic can be used to sort of help stimulate dopamine production in areas of the brain that are hypoactive, such as this. Okay, in working memory deficits, you may need to sort of add something like acetylcholine or something for memory to help with the working memory deficits. Look, ADHD, reduced dopaminergic and noradrenergic tone. Right. And look, frontal striatal hypoactivity. So you don't have as much executive dysfunction. You don't have as much executive functioning, meaning planning, organizing, multitasking, sequencing, because the executive functioning comes from this frontal striatal. And so when you add a stimulant, you're stimulating this frontal striatal circuit, right? So it can become more dominant, and then the frontal lobe can impose more executive functioning tone over the environment. Look, OCD, hyperactivity in orbital frontal loop. Look, excessive error mark. There's hyperactivity in the orbital frontal loop, meaning this orbital frontal loop lost the brakes. And now the circuit is just going on and on and on and on. I need to go through that orbital frontal loop, and we need to sort of increase serotonin as much as possible to try to put the brakes on that circuit. And every time the person goes through the circuit fires, the person has to go through the repetitive stereotypical behavior. And that's what causes this excessive monitoring, OCD. Also, depression, hypoactivity in the ventral striatum, that is the reward circuit, right? Anhedonia and apathy, right? That mesolimbic pathway, hypoactivity, hypodopaminergic activity in the mesolimbic pathway causes anhedonia, decreased interest, decreased motivation. It's the reward center. It's why people use substances to activate the mesolimbic pathway. And so in depression, you see the hypoactivity in here also results in anhedonia and apathy. Let's see here. Neurotransmitter. It says here, would you like me to include a diagram or schematic summary showing the direct and indirect frontal striatal pathways with receptor locations and neurotransmitters labeled on it? Will help you visualize. Let me push yes. This is great. And then while it's making that, I'm gonna go through this. Okay. The neurotransmitters, the major receptors, the role on the frontal striatal circuit. So neuroreceptor, dopamine, glutamate, GABA. Remember, GABA is the major one in the circuit. Serotonin, acetylcholine. Okay, dopamine. Sure, D1 is excitatory, D2 is inhibitory. Right. Reward, motivation, cognitive flexibility. Right. Okay. D1 make it hyperdopaminergic. That means that you get more attention, more concentration, more pleasure, more increased rewards, and things like that. D2 is inhibitory. Okay. All right. Glutamate is active, is excitatory. Again, there are two major neurotransmitters in every tissue, glutamate and GABA. So glutamate, that's one NMDA receptor. Ecstasy is a drug that actively activates NMDA, and it activates it so much it goes through the excitatory process where the cell dies. and because things are turned up too much, you lose the brakes. AMPA is another type of glutamate receptors, and of course, excitatory cortical output. All right, and so starting from the cortex, those fibers going from the cortex down here, like the frontal striatal pathway, going from the frontal lobe down to the striatum. It's excitatory. It turns things on, right? And the glutamate is the neurotransmitter for that. GABA A, GABA B, inhibitory control, and I believe is GABA B is the site of alcohol, right? And I think GABA A is the site of benzodiazepines. I think one of the two. Make sure y'all get that right. And so, alcohol and benzodiazepines like Xanax and all that, this is simply activating GABA that's going to exert inhibitory tone. Why? Because there's too much glutamate, right? Too much glutamate. Serotonin. Okay, 5 serotonin receptors modulate mood and impulse control. Okay, great, we got that. Acetylcholine, the M1 for muscarinic, striatal modulation and learning. Okay, we got that. But so mainly dopamine. So if we want to sort of maintain some control over this network, we want to make sure that we can use our antipsychotics that target dopamine. Now, remember, glutamate receptors and GABA. See, be careful with long-term. I wouldn't suggest long-term benzodiazepine use. You may want to use it in a short term, particularly longer-acting benzodiazepines like clonazepam or Klonopin. But I certainly wouldn't agree with long-term, short-term anti-anxiety medications, benzodiazepines. So remember, glutamate and GABA, depakote lithium causes downregulation of glutamate and upregulation of GABA. So depakote and lithium in combination will be a very useful mechanism to stabilize this. So as you can see, if the patient is having any type of psychoticism symptoms, meaning delusions, paranoia, or negative symptoms, poverty of thought, withdrawn, apathy, there can be destabilization definitely in the dopamine networks. In the dopamine networks, if the patient is overly excited or combative or activation, that's over activation of the glutaminergic networks, right? If the patient is let's say disinhibited, doesn't have the brakes, unable to stop, exhibiting very poor judgment, crossing a lot of boundaries, this may be a GABA issue, a failure of inhibition. So there's no brakes, and so there's no brakes because there's GABA. There's not as much GABA activity. If they present with, like anxiety, depression, anxiety, restless, and everything, it's a serotonergic story. Same thing with acetylcholine. You see here learning and memory, right? Memory, acetylcholine, Alzheimer's disease, right? And so you see here acetylcholine for Alzheimer's disease. Okay, so this is looking great. So as you can see how, if you understand the receptors on this network, then you sort of have a good idea of what medications you can use if you start seeing these type of symptoms, like over here, these symptoms the patients are going through. So here, this is a diagram of the direct and the indirect frontostriatal pathways with the receptors locations and the neurotransmitters labeled. Okay, first time I've seen this, okay. Okay, hold on a second. Okay, guys, I forgot I was doing my presentation. Okay, frontostriatal pathway. Okay, I think it is what it is. Okay, the direct pathway. Okay, direct pathway, indirect. Okay, yeah, I'm not sure I'm getting this. I'm not sure I'm getting this. But I think that's all I want to say for now. This is a frontostriatal loop, the pathway. Hey, keep in mind when you start seeing patients with these type of symptoms, okay? I think that's all I need to say for today, guys. If you have any questions, please feel free to subscribe, like, and share. Otherwise, take care, guys. Read out.